Hello everybody. I'm grateful for the organizers for allowing me to speak to you about whole body MRI for prostate cancer. Here are my disclosures. We will start off by talking about the central role that conventional imaging plays in directing the care of patients with prostate cancer, despite its known limitations. We will quickly move on to the MET-RADS system, which is a multiparametric whole body MRI system that has been designed for the use of patients with prostate cancer. You will learn to recognize the potential uses of whole body MRI in the various prostate cancer states. And I think at the end you will be able to acknowledge that we need higher quality evidence of the management and outcomes impacts of whole body MRI and in fact any next generation imaging technologies if they are going to get more widespread clinical acceptance and if we're going to get paid for these services. So all of us should be aware that prostate cancer is categorized using the prognostic clinical states model, where we have localized disease on your left and advancing states on the right, and by the testosterone levels. But importantly, the presence or absence of metastatic disease and its volume on bone scans and CT scans drives clinical decision making. So for example, the presence or absence of disease, its volume, its distribution affects treatment choices because they are prognostic and predictive of treatment success. So here, for example, is metastatic hormone-sensitive prostate cancer and survival times. And you can see that the distribution of disease is highly prognostic, so patients with lymph node metastases live longer than patients with visceral disease, and the number of sites, for example, on bone scans and CT scans is also highly prognostic. You can also see in these two graphs that the extent of the disease can also be predictive of the success of a therapy. So if you look on the top row, you can see the extent of bone disease is predictive of whether you will get a survival benefit to pelvic radiotherapy in the setting of hormone-sensitive prostate cancer. And on the bottom row, you can see the burden of disease is also prognostic regarding the success of docetaxel therapy, again in metastatic hormone-sensitive prostate cancer. So while imaging is driving treatment, we are also very aware that there are multiple clinical states where the PSA is rising and conventional imaging isn't changing or isn't informative. And one of these clinical states is biochemical recurrence. So in biochemical recurrence, by definition, you have no metastatic disease on conventional imaging. Yet if you have high-risk disease on the EAU categorization, you can see 42% of men actually have metastatic disease, depending on the PSA level, obviously. And we are also aware that in the response assessment state, there are difficulties in monitoring those patients with bone disease using conventional imaging. So let me show you an example of an 86-year-old man who is on a clinical trial and is being followed by regular imaging. And you can see that it has been prospectively called stable over time. He is clinically progressing and was taken off the clinical trial, at which point the PSA level was revealed, and you can see the PSA level had gone up, and you can see that his whole body MRI scan shows that he's getting worse. But on the radiographic imaging, this patient was stable. And this is not at all unusual. So if you look at the third row here, you can see that unequivocal clinical progression with an unchanging radiographic status is seen in up to 40% of men. So it's not unusual to see these kind of findings. So there's a great deal of interest in modern imaging to inform on the optimal management of patients with advancing prostate cancer, because we know that we can see microscopic metastatic disease and microprogressive disease, but modern imaging is disruptive because it reveals the imperfections of the classifier systems on which treatment decisions are made. And one of the next generation imaging technologies is multiparametric whole body MRI. So multiparametric whole body MRI is a multi-sequence, multiplanar MRI with diffusion imaging, and the MET-RADS guidelines on the right-hand side prescribe a core protocol and a comprehensive protocol to be used in the setting of advancing prostate cancer. And here is a patient who has undergone a comprehensive assessment with a sagittal T1 and stir sequence, a Dixon technique in the coronal, and in the axial planes from which we've calculated the fat fraction, T2 imaging, and diffusion weighted sequence. And you can see the MIP image on the right-hand side, which reveals two abnormalities. The comprehensive protocol then allows you to interrogate both of those abnormalities, and one of them on your left is a island of fat poor bone marrow, and on your right you can see that pelvic lesion in fact represented left internal iliac lymph nodes. But the MET-RADS system goes much further than just giving you a couple of protocols. It also provides you with criteria by which you can assess the response of metastatic bone disease and enables you to summarize the likelihood of a response on a Likert scale. So Likert scale 1 and 2 represent response, Likert scale 4 and 5 represent progression. So let's have a look at an example of types of images that would tell you about disease progression. Now, they are stylized on the left-hand side. So I think all of us would agree that an unequivocal increase in the number and size of lesions is progression. The evolution of a focal lesion to diffuse disease is progression. There are no diffusion criteria except one, and that is that any disease that is new has to be in the active range for disease, which is between 600 and 1,000 micrometers squared per second. So here's a man who is clearly progressing. We see new lesions, we see enlarging lesions, and an increased burden of disease, which you can segment out. But what I'd like you to look at is the histogram. You'll notice how the ADC value does not change. It increases from 840 to 930. So it stays exactly the same. And this is what I meant by an unchanging ADC value. Now, response assessment is quite different. Response criteria not only include morphological criteria, but also include diffusion criteria, specifically an increase in the ADC values. So if a lesion disappears, that is highly likely to be responding. If you get the deposition of intratumoral fat within metastatic deposits, that is response. But you'll also notice the presence of ADC criteria for response. So an increase in ADC values is responding disease. So here's an example of a man who's receiving docetaxel chemotherapy for metastatic hormone-sensitive prostate cancer. If you look at the T1 and the T2, it's very difficult to say whether this patient is responding. But on the diffusion imaging, he is clearly responding, evidenced by a reduction in the signal intensity in this particular instance of the diffusion sequences. And of course, it is possible to quantify that also. So you can see how the histogram shifts to the right on this occasion from the active range into the green area, which is an area of increasing ADC values. And of course, it's possible to quantify the histogram statistics. And in this particular instance, you can see how the mean ADC goes from 705 to 1,500. So using this technology, it is possible to show that any PET or whole body MRI is going to be better than conventional imaging. And I think all of us would agree that a PET scan or a whole body MRI scan is going to be better than a bone scan. But the real question today is, how good is whole body MRI compared to a PSMA PET CT? And if you look here at the superiority index, you can see that the superiority index for PSMA PET CT is slightly higher than the whole body MRI. So it's 4.56 against the whole body MRI, which is 4.4. So not far off, but PSMA PET CT is definitely slightly better than a whole body MRI for the detection of bone disease. But we know the disease we see on a whole body MRI scan is prognostic, and this was published recently. And we know that when we look at response assessment, the inter-observer agreement is actually very good for whole body MRI scans, particularly for bone disease. So with this background in mind, we've got radiologists jumping up and down, making some really quite wild claims. For example, they will say the early initiation of treatment in patients with microscopic disease that you can't see on a bone scan and CT scan is actually a good thing to do. That you can change treatment via the earlier detection of microprogressive disease. But the real question is, does this make any difference for patients and their outcomes? And there's been a lot of pushback from clinicians recently saying, actually, this isn't true. What they say is the value of an imaging technology such as a whole body MRI only comes if the imaging helps to maximize treatment benefits or minimize undertreatments, or even reduce or prevents overtreatments while tempering costs. And have we as a community shown that? The answer to that is no. But the real question is, do we need to show that as part of imaging development? The answer to that is no. What we need to do is to show improved accuracy for disease detection. If there are prognostic or predictive improvements, then clinical value is increased, but clinical value has to be shown by a separate set of investigations. And of course, there are other barriers to the adoption of next-generation imaging. So there is a resistance to changing staging and treatment paradigms because therapy approvals are linked to the assessment methods. There are economic forces that drive the use of conventional imaging for prostate cancer because it's difficult to get reimbursement for these new technologies. There are other issues because clinicians don't know how to use next-generation imaging for patient management. And of course, there are changes in the perspectives of the disease resulting from stage migration, from lead time, and of course from length time biases. So if you were going to use next-generation imaging for advancing prostate cancer, what would you use it for? Well, this was recently addressed in the ASCO Guidelines. There are 4 indications that you should seriously think about using next-generation imaging for. Number 1 is high-risk localized and high-risk locally advanced disease when conventional imaging is negative or suspicious. Number 2, high-risk biochemical recurrence. Now, it says there with negative conventional imaging, but biochemical recurrence, by definition, has no metastatic disease. So high-risk biochemical recurrence, it can be very helpful for moving the patient on, because if you were to show the presence of metastatic disease, it would take you to the next row, which is metastatic hormone-sensitive prostate cancer, to clarify the volume and the distribution of disease when upstaging would affect therapy choices. So, for example, if you had biochemical recurrence, that's hormone-sensitive prostate cancer, and you were to show a few spots, you may want to think about using metastasis-directed therapies. Interestingly, you can begin to use next-generation imaging for therapy monitoring in castration-resistant disease because of this issue of clinical progression without radiographic progression. So that is a circumstance in which you can use it. And interestingly, you can also use it if patients are already being followed with next-generation imaging in the treatment paradigm. So you can just continue to use next-generation imaging for that. So here are my concluding remarks. Next generation imaging technologies with PET and whole body MRI undoubtedly increases detection sensitivity and specificity compared to bone scans and CT scans, with multiple potential clinical applications related to detection and response assessments that could transform clinical care. However, we have to acknowledge that clinical and survival impacts have not been shown for the majority of the APC states, and we do need to participate in gathering higher quality data on management and outcomes impacts for clinical acceptance and for payments. But remember, there is no regulatory requirement for you to do so. I hope you found these remarks helpful for your clinical practice. Thank you very much.